Okay. Okay, so my name is Dr. Samina Bilal. Here is my brief introduction because most of you are having first class with me. I'm Dr. Samina Bilal. I'm from Pakistan, Lahore. I did my FCPS, MCPS, and FRCS Glasgow. I'm in fact, a student of Professor Mothu. And I just want to let you know that my field of expertise is basically anterior segment refractive procedures. I have a vast experience in that. So in this case, in this presentation and in this mock exam, you will see lots of cases related to refractive procedures or cataract surgeries where we use premium lenses with the aim to correct achieve excellent refractive procedures. Okay, so do we have any volunteer?
Ma'am, your screen is not visible. Are you sharing anything?
Yes, I am. Wait.
It's not visible.
Okay. Dr. Kaushik, can you give me, actually, I am online from my phone. So
Okay.
I can't figure out how to share the screen. Let me start.
Yes, I think you can start also, or you can send me the presentation by WhatsApp or something. I can show it from here.
Okay, Alina, do that.
Yes. Yes.
I have my
Yes,
daughter assisting me, so just give me a few minutes. I'm very sorry. My apology.
No, ma'am. It's okay.
Progress.
So, send. Just a minute. Okay, so Dr. Kaushik, did you get that presentation?
Yes, when I got that, I just let me just share it.
Okay. Just finished off. It's useless.
Is it visible, ma'am?
Yes, I can see. So first slide with the picture. I'm very sorry, Dr. Kaushik. I'm such a troublemaker. So this is my introduction, brief introduction. I think we have wasted enough time. So let's start here. So is there any volunteer? Anyone? So that I can ask the first question. Okay. So please introduce yourself.
This is Dr. Faisal Afzal from Bangladesh.
Okay. So the first picture, Dr. Kaushik, the next one, this one. Okay. So this is a picture of a 25 years old man who underwent PRK about 3 months ago. After he tapered off the steroids, he presented with some blurring of vision. His pre-laser vision was minus 4.506 with minus 4.506 by 6 in the right eye and with minus 5.506 by 6 in the left eye. So first you describe, and his corneal thickness was, pachymetry was 490 microns. So first question is, describe what you are seeing in this picture.
Okay, I'm seeing the cornea. I'm seeing this is an anterior segment photograph with diffuse illumination. Conjunctiva is mild congested in the inferiorly, and the surface of the conjunctiva there is opacity involving from 3 o'clock to 9 o'clock position. It is stromal opacity. I'm seeing. I cannot say about the cannot say about the epithelium because I want to do the fluorescence stain to see any epithelial defect is there or not. The
Okay.
underlying endothelium, there is no abnormality can be seen. AC is normal and BP seems to be normal.
Okay.
Uh,
I think it's unwise to comment about endothelium on this picture because you can't see it clearly. Okay, so you have described it very well. This is stromal opacity. So I have given you the findings that this person had PRK. So what do you think? What was the problem? What are the factors which can cause corneal scarring in a person undergoing PRK or refractive procedure?
Okay. First one is that there may be the severe thinning of the cornea.
Yes.
During the procedure, there may be the thinning of the cornea,
So basically,
which may
if you
cause
do PRK on thin corneas, there is more chances of scarring. Correct.
scarring. Yes.
So
There may be, yes. There may be, also, if there is any type of inflammation or infection is there, that may also causes the opacity, which I'm not seeing here,
basically, if a person there is interruption in healing because of any reason, so that is the
Mhm.
reason for corneal scarring. So is there any way we can prevent corneal scarring during PRK? Is there any
First of all, we should measure the corneal thickness at the
That is always done. Look,
post-operative.
whenever someone undergoes PRK, it undergoes proper topography, pentacam.
Yeah.
They do measure corneal thickness. Okay, so there is one thing we use operatively during laser, which can prevent corneal scarring. What is that? Use of mitomycin, 0.02%. Okay, so that reduces the incidence of scarring. So now this person has come to you after 3 months. How will you manage it?
Here, first of all, I will prevent the uh, first of all, I will
What
give
investigation
the
will you do? What investigation will you do for this person, which will give you an accurate idea about the level of opacity and how dense it is? Which investigation?
corneal topography.
Yes, that corneal topography will just give you the mapping of the cornea, which is mandatory because if you that will come later in the management part. What else regarding corneal opacity? Like this, you want to measure corneal opacity. What investigation will you do? It will be OCT, anterior chamber, OCT of the cornea. Dr. Kaushik, next slide, can you please show? So the middle one here in this picture, the middle one is the OCT of this person. So can you describe OCT? How much thickness, how much dense it is, what is the level of opacity, so that we can go to the management.
Okay, I'm seeing the G picture G.
Describe the middle one. Middle one.
Oh, okay, the picture.
Yes.
Or the OCT.
That picture, the middle picture is of this patient. So it describes OCT. OCT.
Oh, OCT. So I'm seeing the anterior segment OCT of the cornea after the post refractive procedure. Here I can see the opacity involving the central part of the cornea, involving the whole thickness. I'm involving the whole thickness of the cornea.
No, in the topmost, in the middle picture, in the topmost OCT, it does not involve. It's not full thickness opacity. It's involving the upper one third. Upper 1/3 of the stroma. Okay, so how will you manage this case? So what next?
I can go for the at first the medical management. I can go for the artificial tear and then the superficial keratectomy. I can go. If not, I can go for the deep anterolamellar keratoplasty.
Okay, the problem. Look, so have you ever seen any case which has underwent PRK going for keratoplasty? It's very rare. Okay, so the management you have described well, but you should be very clear what you will do. Medical management involves lubricants can never clear the opacity. Remember, so you have to give a trial of steroids because steroids improve the layout of collagen, so they can improve the opacity a little bit. So first you give 1 month trial of steroids, maybe strong steroid, prednisolone, 4 times every 2 hours, 1 week, then 4 times a day, according to your choice, and you see the response. Sometimes opacity clears, but this OCT is showing that it is the dense opacity involving upper 1/3 of the stroma. So you will have to go for PTK. This person hopefully won't need keratoplasty. He should be absolutely fine with PTK. So we come to, so the management is, so the answer is this person needs PTK. So my next question is, so you are planning this person for PTK. So before PTK, one, you have done OCT. You have measured the opacity. What else? You told me it should be pentacam. Why was that?
To see the surface map, if there is any corneal thinning is there, any places if the corneal thinning is there, to see that one, I want to go for the
basically correct, but pentacam is basically done because remember this is a case of refractive procedure. Okay, so the ultimate aim is to bring his vision close to 6/6. So Pentacam will give a proper, after PTK, you might need to do a little bit of re-enhancement. So you need a primary Pentacam before PTK. And after that, you will look at that and then you can do further PRK again. Okay. So we move on. So PTK, can you tell me how does PTK work? Like what is the principle? What type of laser is used in PTK? Which laser? PTK is phototherapeutic keratectomy, right? Which laser is used for that?
Primer laser is used.
Primer laser, wavelength. What is its wavelength?
Wavelength
193 microns. Okay. It's 193 microns. 193 microns. And how does it work? Basically, it breaks the molecular bonds between the specified stroma. Okay. And what about post-op management? After you have done PTK, right? What next?
I will give the antibiotic drop. I will give the steroid, artificial tear.
Yes.
Yes.
Okay, one last question. So since you have done PTK, so what refractive error you expect after PTK? What kind of refractive error? Because you're removing the stroma basically. In PRK, you also remove the stroma. For myope, you remove the stroma and you are making that person, like making the eye, you are flattening up the eye, okay? So what kind of refractive error you expect after PTK? There will be hyperopic shift.
Little bit like
hyperopic shift. Yeah. How much hyperopic shift?
1.5 diopter or like it's a 2-3 diopter.
That is very vague answer. You can say that if we remove about 40 to 45 microns of stroma through PTK, there can be plus 1 or 1.25 hyperopic shift. Okay, so you have to explain the patient. That's it, I think. Good. So we move to the next question. Dr. Kaushik, we will. So this is the same I have written here. Now we move to question number 2. Okay, so is there any volunteer? It's very easy question.
Ma'am, Dr. Tufaila Shafi from Srinagar.
Okay, Dr. Tufaila. So this is a 65 years old healthy man, non-diabetic, non-hypertensive. He presents to you with pain around his right eye with watering and burning for 2 days. And this morning he noticed that his eyelid is swollen and he has noticed some red eruptions on his forehead. What is your differential diagnosis?
Ma'am, my first diagnosis would be that this patient is having these blisters are suggestive of herpes zoster ophthalmicus.
Yes, but would you like to consider something else? Like differential. Yes, you are right. This is in fact a case of
given this type of given this type of erythematous rash with vesicles and blisters and localized primarily it seems to be localized to the left side of the forehead. My first diagnosis would be herpes zoster ophthalmicus.
Yes. But okay.
Herpes simplex also presents with vesicles, but not in this fashion.
Okay. So can you tell me what are the specific features based on which you say with so much confidence that this is the case of herpes zoster ophthalmicus and not something else like contact dermatitis or vaccinia dermatitis? Can you tell me exactly features based on which? Okay, before that, tell me what will you do next? Okay, I'll come to that later on. So you say this is herpes zoster ophthalmicus. So what next? What will you do?
Ma'am, I will
anything important you would like to know in the history?
Ma'am, hello?
Yes. Anything you would like to know in the history?
Ma'am, if he has any burning pain, because he's comparatively a younger person, if he is on any steroids, any immunocompromise.
He's 65 years old man. Okay. So any history of chemotherapy or diabetes, you must emphasize. He says he's not diabetic, any immunocompromised situation. Okay. So next, what examination you will do?
Examination of the eye. I would like to see if there is any involvement of the epithelium or any corneal involvement, whatever the layer be involved be. And also the rash and hello?
Yes, I can hear.
Corneal sensations.
What next? Will you, and what about the skin lesions? Will you notice anything about pattern? You can see this just forehead.
Yes, ma'am. Yes, ma'am. The rash should respect the midline, though the swelling may go to either side. And there will also be involvement of the side of the nose and the tip of the nose on the same side.
But not necessarily, okay? It's not always the side of nose. So what does that signify if it is involving the side of the nose? What is the significance of that?
Ma'am, that's known as the Hutchinson sign, and that makes the involvement of the, if there is involvement of the tip of the nose, because there is a common innervation by the external nasal branch, and that means that the involvement of cornea is highly likely in such a case.
Yes, not only cornea, but eye also overall. It can lead to long-term complications. Okay, so if it is just restricted to eye or forehead and not involved with the side of the nose, there is a possibility that his eye might not be involved. So in the examination, you will see, look at the cornea. What else? The very important thing you will notice. Anything? IUP. Pressure is very important. You have to see, right?
Yes, ma'am. Yes, ma'am.
And what is the mechanism of rise in IUP in these people?
Trabeculitis.
Yes. Okay. So what next? What will you do now?
Ma'am, ma'am, the first line will be, I will start the patient on oral acyclovir, 800 milligrams, 5 times a daily. Within 72 hours of the rash, it is believed to limit the duration and the severity of the acute episode, as well as also the risk and of the incidence of complications and the risk of post-hepatic neuralgia. This oral treatment I will continue for 7 days. Besides, I will also put the patient on lubricants and see if there is any corneal involvement. If there are pseudodendrites, then I will put the patient on topical acyclovir and lubricants. If the steroid, if the patient does not have any corneal involvement at present, I will not put him on antiviral. Still, there is involvement of the epithelium. I will just use lubricants in that case. And for the skin lesions,
and if there is no involvement of cornea and patient just has burning sensation, what will you do? Because there can be conjunctivitis, episcleritis. So after starting orals, antivirals, you can start mild steroid, fluoromethalon type thing, so that it can reduce inflammation in the eye. Okay.
Okay, ma'am.
And it's better that you refer the patient to the physician instead of starting oral antivirals on your own, because because you are preparing for FRCS, so you have to keep in mind what practice is done there. So you always recommend that I will collaborate with the physician and send the patient to that person. So one last question: is there any laboratory test which you can do on the skin lesions to confirm that it is herpes simplex or some other kind of?
Yes, ma'am.
Is there any
PCR, polymerase chain reaction of the fluid from the blisters can be done?
Perfect. And yes, perfect. Culture for immunofluorescence assay can also be done, but best is polymerase chain reaction. Perfect. Very good. So now we move to the third question. So this one. Okay. Any volunteer?
Dr. Prabhat from Nagpur.
Okay. Dr. This is the 16 years old boy. He presented to you with rapidly deteriorating vision in his eyes for last 2 years. And some doctor did his pentacam, which is shown here. But let me tell you his visual acuity. It is -2 with -4 cylinder at 130 degrees in the right eye, 618 vision. Okay. And in the left eye, it's -3 with -1.50 cylinder at 90 degrees. Visual acuity is 6/9. So it's basically 6/18 in one eye and 6/9 in the other eye. So if you can see this pentacam is done. What do you see? Please describe.
This is a refractive quad map of the pentacam of the right eye, showing the axial curvature, anterior elevation, corneal thickness, and posterior elevation along with the indices. The quality score is okay. I'm sorry. K1 and K2 are in the low 50s, 50.7 and 51.1. The K max, I'm not able to see the K max, but I think it is 58.9. Then if we come to the pachymetry, K max is 63.5. The pachymetry thinnest local is 401, and at the apex is 430 microns. The posterior elevation at the highest point is over 100 microns, so I'm not able to see it very well. This is most likely a case of keratoconus in a 16-year-old male. I would like to clinically evaluate both eyes and then come to a diagnosis, and also look at the pentacam of the other eye.
Okay, so this is the case of keratoconus. Okay, so when you have pentacam in front of your eyes, so this is the case of keratoconus. So what signs, just enumerate, what ocular signs you see in this patient on, just name them.
Okay.
In the eye?
Yes. External examination, we may see Munson sign and Rizzuti sign. Munson sign is when the patient looks down and
yes, just name.
Okay. Then on-slit lamp examination, frank ectasia, Fleischer's ring, Vogt's striae, prominent corneal nerves.
Perfect. And breaks in Bowman's layer. There
Breaks
can
in the
be
Bowman's.
acute eye drops.
Yes.
What else?
Apical scarring.
And at retina, is there anything associated with keratoconus?
Yes, there is an association of retinitis pigmentosa with keratoconus.
So we'll look at the fundus as well, okay?
Yes.
Okay. So now, how will you manage this patient?
I would like to ask history of duration of disease and family history, and evaluate both eyes as I mentioned before, and ask particularly for history of eye rubbing and repeated episodes of allergy, ocular allergy, systemic allergy. I would advise.
So what management? So we are coming to, I know, okay, perfectly. You have perfectly explained that. So what management you will do? Treatment. The person wants some treatment, solution for the problem. What will you tell
his vision? His best corrected vision with glasses is 6/18 in the right eye. So I would like to advise rigid gas permeable contact lens trial to check for visual improvement and tolerance to the rigid gas permeable lenses. And then based on the improvement with the lenses, we may go ahead with dispensing of the lenses. I would also like to advise the patient to avoid eye rubbing at all costs, and advise frequent follow-up with the serial pentacam scans. And if there is progression, then I would like to advise for collagen cross-linking.
Okay, so you won't advise collagen cross-linkage at this stage?
No, on serial pentacam, since it is the first visit, we may consider waiting, although he is a young patient.
Okay.
If he is compliant to instructions, then we can wait and look for progression.
Okay, but in case you have answered correctly, so I don't have any objection to that. However, I believe that if a 16-year-old person comes, you can say that I will go for CXL, but serial pentacam is all right. Okay, so we come to corneal cross linkage. How is it done? What do we use in corneal cross linkage?
We use riboflavin with dextran solution and UVA light of 365.
Perfect. So my question is, why do we use riboflavin? Why not something else? Is there a particular reason for using that, or is it just
it's a photosensitizing agent? So there is a biochemical reaction that occurs, and
but there must be some reason for choosing riboflavin and not some other photosensitizing agent, isn't it? Because
reduced,
number one,
Endothelial toxicity, reduced endothelial toxicity.
Okay, number one, its absorption peak is 370 nanometers, which is safe for the eye. Okay, with UV rays. Number two, it is safe systemically. If it gets absorbed into the body, it will be safe. These are the two reasons because of which we use riboflavin. Okay, so next question is, how will you do corneal cross linkage? Would you do it with epithelium on or without, or by removing that epi off or on? Give me points in favor and against both of them. What about this case? His thickness is 401 microns, central. So what will you do? With on or off?
I would do epithelium off CXL because overall the results of epithelium off CXL have been proven to be better than epithelium on CXL. Having said that, there is an element of risk in this particular case because, like you mentioned, the thinnest pachymetry is 401 microns. Therefore, we would need some additional measures to build up the pachymetry to slightly more than 400 microns. So we have a few options for that. We can use a hypotonic solution, which instead of dextran replaces sodium chloride, or we may use
hypotonic or hyperosmolar. You will use hyperosmolar riboflavin.
Hyperosmolar riboflavin.
Hyperosmolar. Don't say opposite. So you said epi off.
Yes, madam.
Okay, but it's such a thin cornea because if you simply put drops hyperosmolar riboflavin, that will increase the thickness. I don't think you need to remove. I rarely remove. Only if there is very, very early keratoconus and thickness is very high, only then I remove epithelium. So I would say this is epithelium on. Is there any advantage of epi on corneal cross linkage? Less pain, less epithelial haze. These are the advantages we can look for. Is there some contraindication to corneal cross linkage? Is there? If CCT is less than 400, unless you can make up the measure you told me, you very rightly mentioned that you have to increase the thickness. So if thickness is very less than 400 microns, and you cannot make it build it up, then it is a contraindication. Okay.
Yes,
at that stage, person will have hydrops. So in an eye with corneal hydrops or scarring, there is no point in doing corneal cross linkage. Then you have to think about the next thing. So what is the next step? So if a person is not the right candidate and person has developed, so what will you? So in other words, let me rephrase my question. So what will you warn the person if the person is not willing for corneal cross linkage? What will you warn this person?
We need to warn the patient about progression of the disease and the fact that the current glasses and or contact lenses may no longer be sufficient to improve vision beyond a point. In addition, that over a period of time, the scarring may increase, leading to a permanent reduction in vision, or that also, like you mentioned, that there may be occurrence of hydrops if the cornea becomes extremely thin and the Descemet membrane is not able to deal with this strain.
Very good. But then patient will ask you, so what can he do to prevent all these things? Your answer will be, you can go for corneal cross linkage. So summary of this thing is, you will customize your treatment according to the patient. Since first patient is young, if this person was 25 or 26 years old or older, you could go for that serial pentacam and everything. Based on like these progression study, you know that a young person, 16 years old person who is presenting with this complaint that his vision is deteriorating rapidly, plus his pentacam is quite bad. You can see the grading, it is already 50 diopters. So it's better to go to convince a person to explain the prognosis of the disease, to tell that there can be corneal hydrops and scarring, which will lead to the need for keratoplasty. So it's better to go for corneal cross linkage. So there are two parts of the treatment to improve the vision for that glasses or RGP or this, and the second part is to prevent the progression of the disease, and that is corneal cross linkage. More or less, you have. Okay, thank you. You have done very well. I just want you to slightly revise, slightly rephrase your treatment plan. Okay, so otherwise it was perfect. Dr. Kaushik, can we please go to the fourth question? answer? Any volunteer? This is the very short question. Anyone? Dr. Koshi, can we go to the question number 5? I think that is better. I will come to it later on. Okay, any volunteer? This is very good question. Someone should attempt it.
Ma'am, Dr. Soumya.
Okay, Soumya. So, a 45 years old man is a known case of keratoconus and is wearing RGPs for last 20 years. Okay, he's sent to you for cataract surgery. His record shows that his best corrected vision was 6/36 about few years ago, which has reduced to 6/60 now. And in the left eye, it was 6/18, and now it has reduced to 6/24. Patient is concerned about refractive outcome of his procedure. So my question is, what challenges you have in this case?
Ma'am, may I know, has he gone for any refractive surgery as well, or just wearing RGPs?
You will ask these things to the patient. A person with keratoconus, what kind of refractive procedure can that person have?
No, I mean, sorry, the collagen cross-linking, you know?
Is an absolute contraindication, okay? So this is a blunder.
Okay, so ma'am, this person has both the, there are both the problems along with the ectasia of the cornea. He has cataract. So once he goes for cataract surgery, we'll have to first know that the cornea, the ectasia and the cornea is stabilized. And that is why we'll have to calculate the keratometry, which will be difficult to get proper readings in an ectatic cornea. So if possible,
so
if this person...
you have to ascertain the staging of keratoconus, right? This is what you're saying, basically. You have to ascertain what stage of keratoconus this person has. Is it so? This is what you're saying, right?
No, ma'am, I was saying that if we can have the keratometry readings of before he started wearing RGPs, because there might be corneal warpage because of the like gas permeable lenses, and it would change.
But that was 20 years ago. He won't have that record. So what will you do now? He won't have. So you are thinking
one option is we can look at the other eye and the left eye, which has lesser amount of visual acuity, is less deteriorated, might have less keratoconus as well. So we might take that one into consideration.
RGPs even in that eye. So the person should.
We can actually tell him to stop wearing the rigid gas permeable lenses for about 3 to 4 weeks and then do the keratometry.
That is the first thing you will do. Okay, so next. So a person comes back to you after say 1 or 2 months with RGP rest. Now, what problems you have now? You have some challenges. Number 1 in biometry, right? You were saying you will have problem in keratometry. Okay, so what will you do about that? You have to calculate the IOL power. So what will you do now? You will do pentagram. So you have to take. So tell me, what are the reasons in a person of keratoconus which make his or her K readings unreliable? Like, what are the features? What are the things which are hindering the appropriate K readings?
And firstly, the astigmatism in keratoconus is generally irregular. So we don't have a regular corneal surface. And because of the irregularity, they will vary from point to point. And if there is any apical scarring through the scar tissue, we will have a wrong keratometry readings because it won't pass through the scar tissue. So we need the clear part of cornea for a better reading. That's it.
Okay. So there are a few other points, like there will be, because of all these reasons you have enumerated, there will be irregular tear film, right?
Yes, ma'am.
That also is scary. Also, the people who have keratoconus, they have poor vision, they have difficulty in focusing on the target, okay, which results in peripherally displaced visual axis and inaccurate K values. Okay, but you have correctly said, most important is their front to back corneal curvatures, which are assumed by many IOL formulas. That will be different. This is the main point. Okay.
Okay. Yes.
So front to back corneal curvatures, there will be marked difference between that. So So then what will you do? You will use whatever K readings are available from. What is the best method to do that? You can do pentacam and whatever are available, and or as you said, from the better eye, you can use that.
Yes.
Second
Yes,
point,
ma'am.
what will you do for length? Is there any problem in axial length? What will you use for that?
Ma'am, axial length
There
also.
isn't really a problem in axial length. Huh? You
So
can
we
use
can
your
take
conventional A scan. You can measure the axial length.
Yes, ma'am. We can take it.
Okay, the main problem is with K readings.
Yes, ma'am. And with the IOL, we'll have to think about if the astigmatism is very
you have to use
irregular. Then
formula.
yes, ma'am. And we can do the aberrometry as well to rule out higher order aberrations so that we don't use the premium IOLs like multifocals, which would increase his problems with the aberrations and decreased contrast sensitivity.
But do you think a patient with keratoconus will have aberrations? Will he have or not?
Ma'am, he can have, yes, ma'am, because irregularity is there, so he can have.
They have.
Yes, ma'am.
They almost always have. So,
yes, ma'am.
So before that, you have K readings, you have axial length. Which formula you will use to calculate the IOL power?
Ma'am, SRK, the usual. Okay, I don't know actually which one is the best.
Because none is best. Basically, third generation formulas, the SRK2 and the newer formulas, they give comparatively better outcome. However, in keratoconus, you can never promise a very good refractive outcome. Okay, so what kind of IOL?
We would prefer a monofocal IOL. Monofocal IOL if the patient doesn't have a problem in wearing glasses later on.
Look, there are only few select cases of keratoconus where you can use a toric lens. Otherwise, IOL. Otherwise, keratoconus people cannot tolerate premium lenses. Okay, because they have, even in a normal case, a person comes to you for premium IOL, you do the pentacam and sometimes you find higher order aberrations. And in that is scenario for that. In keratoconus, you will definitely have aberrations, and putting premium lens can cause a lot of problem for you as well. Okay, so what is a refractive outcome? What do you aim? What will be your aim with all these measures? What do you aim to achieve?
Ma'am, we can either aim for mono vision in this patient. If the other eye can be corrected for near, like we can make him a slight myopic in that eye, which has a worse keratoconus, and otherwise, that's it.
Actually, the prognosis, you will aim for myopia instead of hyperopia with some astigmatism. You have to explain to the patient that you will have this problem. So if the person is very fussy, let's say, because he is concerned about refractive outcome, so done the procedure, the person gets some number, what measures you can suggest to that person to achieve a better outcome? What can you do for that person for the residual number?
He's already wearing like rigid gas permeable lenses, so he might not have a problem with contact lens wearing. He can continue that.
Okay, and if there is some marked, let's say there is a marked unpredictability in the calculation of IOL because of all the factors you have discussed, and there is unacceptably high myopia or something like this, then any treatment can we do?
Ma'am,
we can sometimes
contact lenses. Piggyback lenses.
Glasses and contact lenses.
Yes,
that can be. That is one option you can offer by explaining pros and cons. Okay, well done.
Yes.
Perfect. Now we will move to the next question because I have wasted enough time in the beginning. So we will go to the question 6. Dr. Kaushik, let's go to the question 6. Any volunteer? This is a very important question. I would like we at least do this one.
Ma'am, can I take it? Dr. Febel?
Yes, of course. Okay, so a 70-year-old man is undergoing cataract surgery for hypermature cataract, okay? And you have done a pre-op examination. You didn't find anything. However, when you start the procedure, you notice zonular dehiscence perioperatively during capsulorhexis stage. Okay, so I would like you to tell me what are the signs which you notice perioperatively. Start from the beginning, which give you a clue that this person has weak zonules perioperatively.
So during the surgery,
like you started the procedure.
Yes,
okay. Okay. So
the AC depth will not be regular. There might be
yes.
One.
Yes.
And when you're trying to do the capsulorhexis, there'll be marked movement of the lens because of the weak zonules, and you'll have difficulty in doing the rhexis. You might also end up in doing a small rhexis.
Okay. So there is difficulty in puncturing the anterior lens capsule.
Puncturing the anterior. Yes, ma'am.
There will be star-shaped striae during rhexis. You will notice
yeah,
and
folds
difficulty
will be there on the rhexis.
Yes. Yes, and difficulty in rotating the nucleus as well.
Yes.
So what will be your next step? You are doing the surgery.
Yes.
What will you do now?
So first we'll have to assess, is it a I mean, full zonulopathy is complete, or it's only in one quadrant clock hours to see how much.
Assess the extent of dehiscence, right? Okay. Then.
So if it's only less than 3 clock hours, maybe we can try to put in a. I mean, either we can try to take the cataract out and put a CTR, or you can before taking the lens also you can try putting a CTR.
So will you do that or not? So give definite plan. So you have noticed that there is dehiscence of 3 clock hours. There is some distraction. Someone has mic on. Can you please switch it off?
Yeah, please. Yeah.
Okay. Okay. So we come back to that. Okay. So will you please give me the definite plan? So you will do. You said you will use CTR, right? Is it so?
Yes, ma'am.
Will you use that?
If it's less than 3 clock hours, yeah, we can try a CTR.
Okay. So at what stage in the procedure you put CTR? Will you do phaco, and after that you will put that, or when will you put that?
That is more preferable, ma'am, because removing the cortex would be more difficult. But if it's
okay, usually it is done at the beginning. You can assess that according to the choice. Yeah. Some people do it as soon as possible so that it gives stability to the band. Otherwise, if it is unstable and you're trying to remove you are trying to, no matter how much smooth you are, there will be more zonular dehiscence. You don't want to do that. So before that, so now your assistant is asking you that what size CTR you want. So what will you do? Do you know what sizes are available, or first tell me what types of CTR, what type of CTR are available, and which one will you choose? It's a simple case. Let's say there is less than 3 clock hours dehiscence. Which one will you use? Let's simplify it. So what size?
You should choose 1 millimeter more than the size of the corneal diameter.
Okay, but do you have time? Okay, so will you measure that on perioperatively? Let's say you don't have time to choose to measure the cornea and everything, and your assistant is offering you 3 CTRs. One is 12.3, one is 13, one is 14.5. Okay, so which one will you choose? Smallest one or biggest
13, the biggest one.
The biggest one. Okay, so basically the trick question here was the size of CTR. If you have the luxury to measure the corneal size, then you have to choose it according to that. It should be, it's both ends should meet, but perioperatively, the question was framed that way, that perioperatively, you might not have that much time. So you choose the biggest one. Okay. So what are the types of, do you know the types of CTR available?
CTR, I don't remember the name.
One is standard, other one is modified, which has a hook.
Chinese.
No. I asked types of CTR. Capsular tension
CTR and
ring.
CT segments are there. CTR is there. No? Name.
Capsular tension devices. How many types? Okay, leave it. So you have put CTR, capsular tension ring, and your bag is still. You proceed during surgery. You notice that it's still, your bag is becoming unstable from another side. Can you do something? What will you do? Can you use another device out of all those are available?
Yes, ma'am. The capsular hooks can be used to hold the capsule.
That's it. And then you will proceed. You will do the surgery, and you will put it that. Any contraindication to the use of capsular tension ring or device? Any contraindication? You're doing procedure. You haven't put CTR right now. Any scenario in which you will not put it?
If the rexus was not properly, I mean, if there is a break in the rexus.
If there is PC rent. If there is PC rent, then
PC rent, yeah, PC rent you will not put. Even if it is a can opener or a the rexus has not gone properly, you cannot put a.
Yes. Okay. I think we have covered it. This question. So just give a read to all the devices available, because this is very favorite question of. Okay.
Okay. Thank you.
So can we do one more question? I think. Let me see. Let me decide which one. Okay, Dr. Kaushik, can we go to the question number 8? That is slightly different. Question number 8 directly. Can I can't see the screen, I think. Yes. Can I see, Dr. Kaushik, can we go to the question number 8? Okay.
Madam, is it visible?
No, I can't see.
Okay.
Question number 8. Can I just ask? Otherwise, I think. Is there any volunteer? I can ask the question. I can tell because aim is.
I can volunteer, ma'am. Anil ma'am here.
This one. Okay. Anyone volunteer?
Yes, I can volunteer, madam.
Okay.
This is Anil ma'am.
So this is a 65 years old man who presents to you with injury to his eye with a finger, like he rubbed his eye. He had a finger poked into his eye. He is diabetic. He is hypertensive, and he had knee replacement surgery about 2 years ago. So he is on blood thinners. So describe what you see in this picture.
This is a diffuse illumination photograph of the right eye. The ocular adnexa appear normal. There is circumciliary congestion. The bulbar conjunctiva in general is quite congested as well. The cornea appears to be clear and lustrous. I am not able to comment about the inferior 1/3. The anterior chamber seems to be having hyphema. One third of the anterior chamber seems to be having hyphema, of which the inferior half of the hyphema appears to be darker, suggestive of clotted blood, and the upper half appears to be bright red, which seems to be an active bleed. The pupil is round. I think the patient is pseudophakic. I am not very sure. I can't comment on the anterior chamber depth.
Good. Okay, so what is the management? What question you will ask in history?
My question would be when did he experience the trauma, whether he had any history of trauma, and what was the mode of injury, whether it was a blunt trauma or a sharp penetrating trauma,
He said
and
that
whether
he
it was
had a finger poked into his eye, forcefully poked
a
into
finger,
his eye.
yes, sorry, yeah, a finger poked into his eye. So my history would be regarding the duration of the symptoms and whether he is having any pain in the eye and whether he has noticed a drop in vision.
So what can be, so this is hyphema, right? In a diabetic patient with knee replacement surgery, what can be the cause of hyphema in this patient? Number one is trauma, right?
Yeah. So
Anything
he's
else?
already on blood thinners, so that is the
Anything else?
reason. Yeah.
But you don't want to be stuck. You want to find every possible cause. So what else?
Other than
Patient is diabetic, right?
Yeah,
can it
diabetic.
Be neovascular
It
glaucoma?
can be new
because of
vessels.
that,
Yes,
right?
yes.
Patient is on blood thinners. Can it be spontaneous hemorrhage? If patient
Yes,
is
it can be
taking
spontaneous hemorrhage.
so basically, this is what you have to consider in the history, right?
Okay.
Okay. So how will you grade hyphema? So what grade is this? You said it is 1/3. It is involving 1/3. So what grade?
Grade 1, doctor?
You said this is grading of hyphema. Can you grade hyphema?
I'm not sure. I think it is grade 1. I'm not sure about the grading.
Okay, so you must read that. Okay, 0 if you cannot see any cells. Less than 1/3 is grade 1. 1/3 to half is grade 2. More than half is, and more than half to slightly less than full is grade 3, and grade 4 is total hyphema. Okay.
Okay.
So this patient is here in front of you. So what will be your treatment plan? What will you do?
Okay, so I will first of all I will check the extraocular movements. I will check the pupillary reaction. I will stain the eye because he has a fingernail trauma. I would be careful to check for any corneal abrasions, and I will also check the other eye for any evidence of neovascularization or of the iris because he's a diabetic. And once this is done, I will most importantly, I will check the intraocular pressure. So that will be the key factor for me.
Yes,
so
that is most important.
Yes. So I will measure the intraocular pressure using Goldman's attenuation tonometry, and based on that and the duration of the presentation, I will decide on my further management, whether it will be a medical management or a surgical management.
So this patient has trauma to the eye about 1 day ago. So what will be your treatment management in this case?
Okay, if the intraocular pressure is less than 60 millimeters of mercury, since it is only since it's only a 1 day history of trauma, I would treat him medically if the intraocular pressure is less than 60.
But will you do dilated fundoscopy to rule out, as we said, he's diabetic? Will you like to rule out all those things?
I would like to rule out. I would like to rule out any diabetic retinopathy.
Would you like to, yes, and would you like to check his INRs, bleeding disorders, because he's using, will you collaborate with his physician, orthopedic surgeon regarding his blood condition thinning? These are the 2 mandatory things. You will check his blood pressure and neck. Now, will you do medical management or surgical management? Be very clear about that. Will you do medical management?
I will go for medical management right now.
Okay, so what will you advise to the patient? What treatment will you
I
give?
will
His pressure,
advise.
let's say his pressure is normal. Okay, you can see this
Okay.
hypema. There is you will see, look for corneal staining, right? So what
Yes.
treatment? That is not obviously in one day. Usually there is no
Yes.
corneal staining. Is there any exception? Okay, so what will you do? What will you advise to this patient? Any about like?
Okay, so I will first of all I will advise the patient to sleep in a propped up position with at least a couple of pillows, and secondly I will start her on topical
Why is
steroids.
that? Why do you want
So
this
that
person?
so I want to do that because so that the hyphema doesn't get dispersed in the anterior chamber and
So it
gets
settles down, so that
time to settle.
it becomes organized. Like in this case, you said the lower half is darker and upper part is slightly, that this is not rebleed. In fact, this is basically that person is in erect position, so that is sedimenting in the lower half. So you want to keep to protect the visual axis. So you will ask the person to lie in 45-degree position, and bed rest. What next? Medicines. What drop will you
Medicines
use?
I will use topical prednisolone acetate 1% eye drop at least 6 times a day.
And why is that? Why do you want to give
Because
steroids to this patient?
The eye will be inflamed and there will be a significant cellular reaction in the anterior chamber. We want to control the
If there is
inflammation.
no, let's say if there is no reaction in the eye, will you give? Because look, the eye is full of blood. These cells can block trabecular meshwork. They can increase IOP.
Yes.
Okay, so you should be more about beta blockers and all these things. IOP lowering.
Yes.
You will give prophylactically that. And yes, you can give steroids. And if you find any abrasion, you will treat accordingly. Okay, so
Yes.
here,
Yes.
so far we are okay.
I
So
will give beta blockers. Yes.
Anything, if you have to give IUP lowering drugs, which one will you prefer in a case of hyphema?
I will prefer going for beta blockers and carbonic anhydrase inhibitors.
And alpha agonist. Okay. So any
and alpha
conditions where any particular condition, reading disorder you want to know in the history, you want to find out about sickle cell disease. That is the only thing which you are more concerned. Okay. So if the person has history of has sickle cell disease, then everything changes. Then your criteria will also change for the treatment. In that case, alpha-1 agonist and all these things are contraindicated. Okay, so you have given the medical treatment. So at what stage will you decide that this is the time to go for surgical intervention and medical treatment is not enough? What happens? What are indications?
If the IOP remains elevated to more than 25 millimeters of mercury for at least 5 days, if there is corneal staining which has started to involve the visual axis,
and
if the hyphema increases, if it is increasing in size.
Why will hyphema increase in size? He had trauma about, let's say, 1 or 2 days ago. So what is the what thing can cause increase in hyphema?
Clot retraction.
There can be rebleed.
Yeah, rebleeding.
And what is the cause of rebleed? Why does it happen?
He's on blood thinners, so that can be one reason.
Otherwise, if he's not on blood thinners, then
ma'am.
Yeah.
Yes.
Then
ma'am, may I?
Yes, you may.
Ma'am, there is clot retraction.
Okay. Yes. So there is clot retraction, fibrinolysis, and there can be rebleed. So if there is rebleed, will you immediately go for surgery, surgical evacuation, or you can try some things?
If it is a rebleed, I would not I will have to assess the extent of the rebleed. If it's a small rebleed and intraocular pressures are controlled, I wouldn't go for surgery immediately. I would
But you
again
have to
try
do something
with
about this case. Okay, perfect. This is right answer. So will you give anything Any medicine?
Medicines.
Transamin, topical
like
aminocaproic acids which inhibit fibrinolysis. We can use that.
we can give
Okay. You observe for some time, few days, and if it becomes full or involves visual access and you think it is increasing, that you can go for surgical evacuation. Okay. Okay. So what can be the complications of hyphema? If you do not remove it timely, you have already told me, just enumerate that. Let's say I ask you, what are the complications?
Rise in intraocular pressure.
Next.
Corneal blood staining.
Yes. Rebleach. Synecdoche formation. And there can be pupillary block.
Formation. Pupillary block.
Perfect. Is it enough?
Ma'am, I have a doubt. Ma'am, if in case of a hyphema, they say that the IOP is normal, like maybe 17. So should we still give IOP lowering drug or can we omit that?
Either you keep the person under strict observation, like if you have hospitalized the patient and you are measuring the IOP or patient is coming daily to you, then you can omit that. Otherwise, there are chances that those cells will trap the trabecular meshwork, and if you can give prophylactically beta blockers, I think there is no harm in that.
Okay. Thank you so much.
Okay. Dr. Kaushik, is it enough? Or should we do one more question? Can we go to if anyone wants to do a quick question, quick 5 minutes question. Any volunteer? We can do it and finish in 5 minutes. Question number 9, Dr. Kaushik.
Ma'am, can I take it up?
Yes.
Yeah. So a 47-year-old woman.
Let me ask. Okay, 47 years old, high myope patient is referred to you for cataract surgery. Okay. So that person, what challenges? That person is also very eager to get rid of glasses and or near perfect outcome. So what problems you can have in this case and how will you proceed? Starting from the history. 47 years old woman.
Okay. So first thing is I will assess for vision in both the eyes. And I will look for any, I will also do Hirschberg's and look for any deviation, because in high myopes, there are chances that the eye which is very on the side of very high myopia has chances of having amblyopia. So they may have exotropia in that eye. So, and apart from that, I will also check for optic nerve function like visual acuity, pupillary reflex, because they also have high chances of having optic nerve dysfunction.
Okay. Anything in the history you would like to know? Anything?
Change of glasses, any family history of high myopia, any family history.
Any refractive procedure. Look, any refractive procedure patient have undergone or not, because that will markedly change your IUL calculation.
Okay.
So refractive procedure as well. You will look at the retina more for retinal breaks, retinal detachments, any degenerations, because in this case, your more basic focus is that there shouldn't be any untreated degenerations.
Yes.
Okay. So what will you okay, how will you proceed? Do you think there will be some problem in this patient? In biometry, you can have some problems.
Yes, high myopes, they can also have staphylomas.
Yes, they mostly have to some extent. Okay, so
I would prefer to do an IOL master. And
however, even IOL master, sometime even there can be error.
Yes.
And it can sometimes underestimate, and it can contact immersion technology that can overestimate. So important thing is you will use IOL master, you rightly said, but you will tell the patient that in high myopes, there can be refractive errors. There can be some residual refractive error. Counseling the person is very important, okay?
Yes,
Any problem in K readings? I
Mm.
don't think so. Huh? K readings you can take regularly,
Yes.
unless the person has very high myopia and is at the point we discussed in keratoconus. If the person is unable to focus, then their visual axis deviates, and K reading that takes the readings of periphery. So in that case, preferable method is if you have pentacam, you can use those readings. They are better accurate. Okay. So formula for IL calculation in myopes.
Barrett formula.
Yes, the fourth generation. Although you can use SRKT and all these formulas, but they usually underestimate the power.
Okay.
So Barrett universal formula or any one of these you can use. Okay. So what about IUL selection? Sometimes myopia is high. There are chances that a person might not need any number. So will you leave that person aphakic, or will you choose any lens? And what will you do? What will you prefer to do about that?
Yes, so based on the IOL power, if it is near to 0, then we can leave the patient aphakic. But yes, I explained to the patient that there are chances of refractive surprise, and if required, he might need a secondary IOL implantation at a later date.
Okay, so if you leave a patient aphakic, is there any problem you expect? Are you making that person prone to some problem? Aphakic retinal detachment?
Yes.
So it's always wise. I would say don't leave eye aphakic.
Okay.
Always put some kind of lens into that. Okay. So, okay, so you have calculated the length. So any precautions? Now you have taken the patient to the surgery. Any precautions? Perioperative, intraoperative, and peroperative. Any problems you can have? Perioperative. Will you give anesthesia? What kind of anesthesia you will give?
We will most likely it is better to do under topical anesthesia.
Yes, you won't give retrobulbar.
Yes.
Mm-hmm.
There's a high chance of perforation if we are giving a perivalvular.
So you won't do that, right? So you must tell confidently your plan that I won't give retrobulbar anesthesia because there are high chances of perforation. So intraoperative, what problems you can have in high myopic eye when you do cataract surgery? They have very deep AC, interior chamber.
AC, fluctuating. So we have to constant, they all, and they also have
very large capsular bag, okay?
Yes.
Very large floppy capsular bag. Sometimes they even have capsular dehiscence. Very large eye, high myopes. Sometimes they can have, so you have to be careful about that. Okay, so peroperatively, what measures you can take? All these you have said, all these things, deep AC, large bag, and all these things. How can you overcome all these problems? But what things you will do during surgery? Anything about incision? Small incision, minimal incision, peeling.
Yes. A
right?
small incision, and I will keep the bottle height slightly higher so that the anterior chamber is always deep and maintained to reduce the amount of.
No, I think if you keep higher,
then the AC will be deeper, but
no, you will lower the AC bottle height. I think I think you will lower it so that there is a uniform pressure into the. If you do it higher, it comes with more flow, and it causes fluctuation in the flow. You keep it lower and you maintain it, but we will check it. And use of viscoelastic. Okay, so any complications? So important is, if you are doing a surgery on myope patient, what refractive error you don't want? What is the preferable outcome and which you don't want at all? Like if that person is, what will you prefer? If the person is myopic or hyperopic?
Sorry, ma'am. Your voice was breaking. Can you please repeat the
Okay.
question?
So my question is that after the procedure, what refractive outcome you would prefer for this for a high myope? Slight myopia or hyperopia?
Slight myopia.
Okay. And okay, so what complications in a smooth, uneventful surgery of a high myope? What complication you can still have afterwards?
Retinal detachment.
Retinal detachment, retinal break. And will you do anything about that before procedure?
Yeah, a barrage can be done. Prior
okay, so you should
cataract.
have, so you should mention that. Okay, so
Yes.
you can say that if I find, and which you will find usually, even if when you're operating a high myope, do let them know. You will discuss with the patient possibility of retinal detachment, and you would like to do retinal barrage laser to secure the posterior pole or any breaks you find. Okay, so what else? What complication? Refractive error. Usually myopes have hyperopic shift because of all those reasons we have discussed. Okay, so IUL power A, because they have staphloma and their axial lengths, they gets underestimated. So there can be hyperopic shift. So this is very common, more common to find hyperopic shift in there. And what else? If you put a sulcus IUL in a myope patient, what can happen to that? That can be easily decentered because it has large floppy bag.
Yes.
And any other complication at the retina, they are more prone to cystoid macular edema.
Okay.
Okay.
Yes, ma'am.
Okay, I think it's enough. Very well done. I think Dr. Kaushik, that is enough. And thank you so much for your cooperation.
Thank you, ma'am.
Thank you, ma'am.
Yeah, you're welcome.
Thank you. Thank you, madam.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you so much, ma'am. Ma'am, can you close? Thank you so much. Thank you.